So it is now my pleasure to introduce the one and only Dr. Richard Silver to speak about polycythemia vera. Although he does not need an introduction, Dr. Silver is at Weill Cornell Medicine, Professor Emeritus and Director of our MPN Center. Dr. Silver.
Thank you. So this is our 12th patient symposium. I had the honor and privilege to do 11 of them. I've now passed the baton to Dr. Abizena. Let's give him a big hand. And of course, he's ably assisted by Dave Booley. So let's give Dave a big hand. And of course, the patient committee, all of you who were here, and it's been so heartwarming for me to have loads of patients come up and say, do you remember I saw you 30 years ago? And I was at Dr. So-and-so's office, who I won't mention. And here I am, and I'm feeling great. So to all your patients, thank you very much. So my disclosure, I'm involved with interferon through Pharmacentials, just by way of disclosure. And I'm going to do something a little different. I'm going to acknowledge our team here at Weill Cornell at the beginning of my talk, because so much of it really represents what we do together. And I'm particularly pleased and proud to acknowledge the work of Gaith Abizena and Joe Scandura, because they did a lot of the artificial intelligence work that you will hear later on. And our assistants, Katie and Neville. Where are you, Katie and Neville? Katie, no, let's stand up. There, stand up, okay? Because you can't do that. And a lot of these great ideas come from collaboration with people like Ron Hoffman and Naveen, but the interferon people are really the Europeans. And Hans Hasselbach has come all the way from Denmark to join us. Hans, where are you? Please stand up. I'm so happy to see him. He was a real collaborator. Thank you, Hans. Dr. Spivak is unfortunately had a medical event this past weekend, and he's perfectly fine, but he can't travel. You'll hear his presentation. And he and I have chaired the 15 congresses. We have them every year now, so it's our 22nd year. And I hope a lot of the patients will come to the Congress in Brooklyn tomorrow and Friday. So I'm going to talk about polycythemia vera, and I'm going to define it in terms of patient verbiage. I'm sure some of you are more familiar with the more sophisticated terms, but let's use some commonality in words. We can say it's an excess proliferation or manufacture of young red blood cells in the marrow, leading to increased red blood cell in the blood, and this makes the blood very thick. And as a consequence of this red cell manufacture, the iron stores in the marrow are depleted, and so patients are iron deficient and suffer the consequences of iron deficiency. It's almost always accompanied by increased numbers of white blood cells and platelets, because this JAK abnormality is pervasive, as we'll see in just a minute. And the above is due to this mutation or an abnormal alteration in the structure of a JAK gene. And the normal JAK gene, as you already heard this morning from Dr. Hoffman and Dr. Naveen, is that it is a gene that is involved in all kinds of cell production. So this is a very important normal gene. It is involved in all kinds of cell signaling, manufacture, cell death, etc. And the abnormality of this gene leads to some of the things we see in polycythemia vera. So what is the JAK gene mutation? The normal gene, as I said, is extremely important in how cells signal to each other. The abnormal gene, that's JAK V617F, that really just defines where the molecular abnormality is. And even among our cells, we just call it JAK, or abnormal JAK, or JAK positive in our writing, is found in almost all cases of PV. And this is very important because it distinguishes many other causes of increased red blood cell counts. Like if you go to high altitude, even Denver or Mexico City, people have a high red blood cell count. They come back, see the doctor, You heard that ET can be diagnosed serendipitously by Dr. Scandura. So you just get a JAK test. If it's negative, you know it's not PV. However, this JAK gene is also found in about 50 to 60% of patients with ET and myelofibrosis. And this leads to some problems in the early diagnosis of ET and MF because they can be phenotypically or share common symptoms with PV, so we have to be very careful about this. So what is the cause of PV? The increased red blood cells causes thick blood, increased viscosity, and many symptoms are associated with this. And for many years, we overlooked, when I say we, our physicians overlooked the fact that patients with polycythemia vera are really symptomatic when they're first seen. And if you look in the records like Katie and Neville did, you find that nearly 85% of patients reported symptoms of fatigue, dizziness, weight loss, pains and aches in their legs, and it's in the doctor's record, and yet the doctors didn't pay attention to this. And it was really Ruben Mesa that deserves the credit for really going and exploring the symptoms that are found in patients with MPNs, and we published recently a paper on the symptoms of polycythemia vera that occur early in the course of the disease, and as I said, 85% of them have that. Now, as you know, the increased red blood cell count, as you can heard already, causes thrombosis in about 25% of patients at the time of diagnosis, but there's also a little incidence of thrombosis as the disease progresses, as you'll see in just a minute. And later, the breakdown products of all these blood cells, the red cells, white cells, and platelets, cause, because of the biochemical reactions, some of which you heard, to scarring of the bone marrow, which we call fibrosis. And the fibrosis eventually leads to anemia and an increase in spleen size. And this is a picture of the first patient with polycythemia vera, first described by William Osler, and his blood was so thick that it hardly flowed when Dr. Osler cut the vein to get some blood samples from him. So the initial treatment of PV, we all agree because of that we must phlebotomize patients. We remind people that men and women have different blood cell counts. The normal hematocrit for a man is around 42. For a woman, it's around 39. But the target that we use in PV is for a man 45% and a woman 42%. I might add that nobody has ever done really prospective studies on evaluating these hematocrit values, but we at Cornell and at Hopkins and other places make a distinction between men and women as far as our phlebotomy targets. Now, how many phlebotomies do patients need? No one has this data except us at Weill Cornell, and we published this some years ago. The mean and median is about 7 to 8 per year, but you can see there is a broad range, just like you might expect in any disease, of how many phlebotomies a patient will require. And this is very important because you can't compare a patient who needs 20 phlebotomies a year to one who needs 1 or 2. And in the drug trials, as you will see with ruxolitinib, this is very important. And in other trials as well, because those patients who have a high phlebotomy requirement are quite different than those who have a low phlebotomy requirement. So the treatment options in PV after the initial phlebotomy to the hematocrit of 45 to 42 is really contentious. There are some people who continue phlebotomy, and that is used in underdeveloped countries more often than not because it's inexpensive. But even in developed countries like the United States, Canada, Mexico, that phlebotomy is still suggested as a treatment of choice. Hydroxyurea is the most commonly used drug worldwide because it's inexpensive and effective, but nonspecific. But we prefer interferon here at Weill Cornell, and some European centers, they share this enthusiasm, including Denmark, Dr. Hasselbach, Kalajian in Paris, and Gislinger in Austria, and you'll hear about them, for those of you who are coming to the Congress tomorrow and Friday. And ruxolitinib after hydroxyurea is a very popular form of treatment. We'll explain why we don't like that as a treatment of choice preferentially. So we believe at Cornell, as I mentioned, that interferon should be considered for both low and high-risk patients with polycythemia. And just to remind you, low-risk patients with polycythemia are under the age of 60 with no history of thrombosis. And high-risk patients are those over the age of 60 and or a history of thrombosis. And this is a standard categorization used by the European Leukemia Net all over Europe. And you already heard of the NCCN. Dr. Naveen mentioned that. That's the Advisory Cancer Center Board. So that is a standard criteria used by the World Health, by the European Leukemia Net and also by the NCCN. And then we use that too with some reservation. Now for low-risk patients, the ELN recommends phlebotomy only, but recently suggested interferon in selected cases. And for high-risk patients, they use hydroxyurea and interferon in selected cases. The NCCN, with a little more enthusiasm, that's why it's a 2B recommendation, for phlebotomy or interferon. And for high-risk patients, they share the same view as ELN, hydroxyurea or interferon. And here, Weill Cornell, we believe that interferon is superior to phlebotomy for low-risk patients and superior to hydroxyurea for high-risk patients. And we'll explain why. So the one thing we really object to is the phlebotomy-only method of treatment. Much like this patient being phlebotomized in the medieval ages for some unknown reason from a tapestry that comes from Italy. The maintenance phlebotomy causes increased severity of iron deficiency, and it should be noted that as patients develop an increased red cell mass, iron gets absorbed from the marrow into the developing young red cells, and typically 95% of patients with polycythemia vera, when first seen, are iron deficient. And there are clinical issues associated with iron deficiency superimposed on the symptoms of P. vera, and they are listed on the left. The clinical issues include additional fatigue, pruritus, cognitive impairment, frequent falls, dementia, etc. You can read that. And they're associated with basic fundamental biochemical abnormalities listed on the right, including dysregulated iron metabolism, which is very important. You'll hear about that later on. DNA synthesis and mitochondrial dysfunction, etc. So there are basic clinical and laboratory abnormalities associated with iron deficiency per se. And in fact, phlebotomy only as a treatment of choice is not possible. And in a French study that was performed years ago by a mentor of mine, Dr. Najin, he pointed out that 50% of patients were off a study of phlebotomy only at the end of 3 years, and at the end of 9 years of study, there was only a few patients left being phlebotomized. It is a treatment that cannot be continued for the great majority of people, and this is documented a long time ago in the literature. One drug you should be familiar with, speaking of iron deficiency, is this rusfertide. And this is a drug that has been championed at Mount Sinai by Ron Hoffman and his group, and we've had the privilege of participating in some of the phase 2 studies with this drug, and Ellen Ritchie is going to present this at ASH. This is a drug that interferes with absorption and metabolism and distribution of iron. The phase 2 trials were extremely successful. It cut down on the phlebotomy rate. It reduced the symptoms of iron deficiency significantly. It should be noted that it does not affect JAK2, the abnormal JAK. So it does not stop, in our opinion, the progression of the disease, but iron metabolism is significantly affected. And there are other hepcidin mimetics in development, so this area is a very fertile ground for our interest and pursuit. And for the fellows who may be in the audience, there's an excellent review. I put it in here in Blood just this year in 2020-2023. So for these reasons, myelosuppression was recognized by the old Polycythemia Vera study group. That was a cooperative group established at Sinai years ago. They recognized that chemotherapy should be an adjunct to phlebotomy. Chemotherapy relieved pruritus and other symptoms. It diminished splenomegaly when patients developed that, and it controlled the blood counts. Unfortunately, the chemotherapy they selected in those days, chlorambucil and radioactive phosphorus, led to the development of acute leukemia in about 25% of patients by 5 years. So that was obviously unsatisfactory. And the drug that was selected that did not have this potential to cause leukemia was hydroxyurea. This is now highly effective and most widely used suppressant around the world. In new patients, about 75% effective. Not all patients respond. If you're previously treated with an alkylating agent or any other drug, it's much less effective. It's a non-specific cell poison affecting DNA metabolism and has a definite increase in skin cancers. You heard that. And we believe, as does Dr. Hasselbach, who wrote an excellent review with Dr. Spivak on this drug a few years ago, that if you use it long enough in an efficient dose, you will end up developing acute leukemia. And this is French data, which we share. And it also has this curious cutaneous toxicity. Unfortunately, many patients go to dermatologists who have no idea that hydroxyurea can do this. And this was a painful ulcer in a patient, which is seen in about 20% of patients who went for almost a year with unrecognized disease. So we became interested in the specific activities of interferon along with Hans about 25 years ago, but I reported it first. Sorry, Hans. And the reason that we are interested in interferon is that interferon activates dormant PV stem cells, and you heard Dr. Hoffman talk about how important stem cells are. And it's been shown by Anne Mullally in Harvard and others that in PV, it leads to their exhaustion, and that also occurs in stem cells of normal individuals as well. Second, it's involved in this JAK-STAT signaling, which I talked to you about, and it's safe to use during pregnancy, and a number of our young patients with PV are pregnant, and that's very important. Hydroxyurea cannot be used during pregnancy because it affects the fetus, and it's not leukemogenic. Now, you've heard a lot about interferon, and I thought of how I can explain this very simply, and this is it. There are 3 types of interferon, type 1, 2, and 3. Type 1 is the one you should only think about, and type 1 interferon has 9 types, 2 alpha and beta, and 7 others. There's alpha, beta, gamma, delta. Forget all those. The only ones you're interested in really is an alpha, and then alpha has 16 subtypes, and that's just based on the structure of the interferon molecule. So of all the 3 interferons, we're only interested in interferon type 1, and that is alpha 2, and that's a nomenclature. That's where it comes from. Just for completion, type 2 is a value in chronic infectious diseases like resistant tuberculosis, and type 3 it also occurs as in viral diseases like type 1, and that's very similar to type 1, as I just mentioned, and very little work has been done on that. Now, what's pegylated interferon? There we go, what's PEG? So pegylated interferon, it's underlined PEG. It's a polyethylene glycol. That's just an inert substance that is tagged to the interferon so that when you inject it, it stays around a little bit longer. But there is, as you'll see in just a minute, there's no difference. There are 2 commonly available forms, PEG interferon alpha 2A, just by structural differences that is linked by a special chemical bond known as an amide bond. And this is made by Roche. And then there is now rho-peg interferon, which is a long-acting interferon linked through a proline bond, which is made now by Pharmacentia in the United States, or distributed by Pharmacentia in the United States, and AOP often in Europe. And the difference between the two is that Roche product has about 11 different types of alpha-2A interferon, 11, whereas Roferon has only one. And so it's been suggested, rho-peg interferon has only one. So it's been suggested by Pharmacentia that the toxicity of that drug may be less than the Roche compound, but that has not been shown to be true as yet. So the side effects you've heard about of interferon therapy is pervasive because type 1 interferon is an antiviral interferon. When you get the injection, people feel the side effects of the interferon that the body makes normally in response to the virus. And so you get body aches and pains, and therefore Tylenol, or I should have mentioned Tylenol. What's the trade name? I mean brand name? Not brand name. Acetaminophen, right, thank you, is very helpful, or aspirin. And we have seen at Cornell every one of these side effects. That's where this comes from. Hopefully, and we know for a fact that they are all reversible, but that is why you need to be under the care of a physician who really knows about the side effects of interferon. So are there qualitative differences among the interferons? At the present time, the evidence is quantitative, not qualitative, not whatever you read. There is no evidence that the toxicity profiles differ, and the differences are, as usual, the result of the doses, the enthusiasm of the doctor, the tolerance of the patient. And as you already may have heard, the current studies would indicate that toxicity rates with interferon hydrea are about the same. In current studies, they range around 8 to 10%. So the treatment of polycythemia vera started about 30 years ago, adapted from chronic myeloid leukemia, because as you heard from Dr. Hoffman, there are many characteristics shared between the MPNs, and there are many characteristics of CML shared with PV. And in CML, we ended up using low-dose interferon, and that was what we did in patients with PV. With just using regular interferon, it was 1 million units twice a week, 3 times a week. And with pegylated interferon, we still use very low doses to start. Now, the PVSG, this polycythemia vera study group, the end results of the trials was a hematocrit of 45%. No phlebotomy requirements, because even then it was recognized that phlebotomy caused iron deficiency, which was ill-advised. And we noted that interferon was even successful in patients who received prior hydroxyurea. A few years ago, Hans and I reviewed papers pertaining to the phase 2 studies, that is, not randomized trials, of the use of interferon in PV, and we thought we could influence the regulators to authorize the use of this drug in an official capacity, and unfortunately that was unsuccessful. But the basic principles of using interferon was summarized here, and the successful trials that I referred to just a minute ago were those that start with low dose, increase the dose slowly, and notice it takes 2 to 4 years for a complete hematologic remission or significant reduction in JAK2 to occur, and that the end point was to make the patient phlebotomy-free. This is from our original paper here at Cornell of 55 patients, and you'll notice that in blue and yellow, the difference of whether or not patients had splenomegaly didn't make any difference. At 2 years, 90% of the patients with initial splenomegaly showed greater than a 50% reduction in spleen size, whether or not they had received prior hydroxyurea. So that's far better than the results with HU and with ruxolitinib, and we'll explain that difference in just a moment. And it didn't make any difference, as I said, whether the patients had a splenomegaly or not, but the spleen became non-palpable in 70% of the patients. So finally, there have been 2 randomized trials, and you heard Dr. Hoffman, Dr. Naveen speak about how important randomized trials are. There have now been 2 randomized trials, one in low-risk PV, led by Dr. Barboui from Italy, and the other, this study in high-risk patients, those over the 60 years or with a history of thrombosis, led by Dr. Gislinger from Austria. And that led to the approval of interferon in Europe, Ro-Peg interferon, and eventually in the United States. So in the low-risk patients, which was Ro-Peg versus phlebotomy, led by Dr. Barboui, there was a decrease in the number of phlebotomies. There was a decrease in the severity of iron deficiency, reduction of disease-related symptoms, normalization of counts, and there was a progressive disease in JAK2 allele burden. And in the high-risk patients, the so-called Conti study, continuation study, you'll see, although there was a favorable result with hydroxyurea, eventually at the beginning of about a year and a half, patients in the squares, patients did much better on interferon compared to hydroxyurea. And you notice in the lower diagram, the gradual decrease in the JAK2 allele burden on interferon compared to the upper curve, which is a high allele burden seen in patients with hydroxyurea. And in a recent publication that just came out, the probability of any kind of bad event in PV treated with Ro-Peg on alpha-2b compared to hydrea was significantly different. The top is a PEG interferon, and the lower one is the hydroxyurea arm. So there's a significant difference in complications. So we thought at Cornell that there were many reasons to use interferon initially. The ELN guidelines, as I mentioned, were just based on age and thrombosis. They don't account for symptoms, which I talked to you about already. Younger patients have more aggressive disease. We showed that in a publication led by Dr. Abizena. And long-term development of myelofibrosis has not been considered. Hydroxyurea is satisfactory, but is not disease-modifying. Interferon is a disease-modifying drug and relieves symptoms. And finally, we have these 2 phase 3 studies, which I talked about already. And to summarize, in low PV, interferon is better than phlebotomy. And in the PROUD study, interferon is better than hydroxyurea in the high-risk patients. But we believe that interferon is better than hydroxyurea or phlebotomy in high-risk and low-risk patients, respectively. So we have, because of a long history of treating these patients, examined 470 patients, and because we have a sort of a close-knit group, 60% of them were treated by only 4 physicians over the course of years. And Dr. Abizena and Scandura developed, along with our IT people, a method for extracting data, which you see on the left, and then a method for querying certain questions that you can ask. How many patients had a spleen? How many had symptoms? How many had a bone marrow biopsy, et cetera? And there were 2.5 million points of reference in 8,000 patients in 470 patients. And what was noted was on the left, in the left-hand corner, you can see there's an increased arterial and venous rate of thrombosis, which we expected in patients with PV when they were first encountered. But note there's a slight risk of thrombosis seen in these patients as disease progresses. But more important, there was a development of myelofibrosis beginning about year 10. What was looked at, the myelofibrosis-free survival, or the development of myelofibrosis, you can see that it was 86% in patients treated with interferon versus 56% with patients treated with phlebotomy only and hydroxyurea in between. So that this was a significant difference, indicating that interferon prevented the development of myelofibrosis in a significant fashion compared to phlebotomy and hydroxyurea. And overall survival was even more incredible than at 20 years. There was a 68% survival with the interferon patients compared to a 16% survival in the phlebotomy-only group and intermediate with hydroxyurea. So what was more important was we found that the longer a patient receives interferon, it reduced the risk of myelofibrosis and also improved overall survival, and that risk was shown to be a certain percent, 9% and 6% respectively every year. Now, there's also qualified and quantitative changes in the marrow in patients developing early myelofibrosis, and I point this out to Dr. Hoffman in particular, because I think interferon is a very effective drug in treating early myelofibrosis. On the left, we won't go into that in detail, are all the changes you see in PV, a hypercellular marrow, lots of megakaryocytes and fibrosis. And after 2 to 3 years, you can see normalization of all these abnormalities. And these data were absolutely confirmed by Dr. Naveen's group at MD Anderson and also by Hans Hasselbach in Denmark. Of course, you have to do frequent biopsies to document these changes. The response to this interferon treatment is shown dramatically here. 70% had stable disease, 50% had achieved a clinical improvement, and 30% developed a partial or complete morphologic response. So we treat all our patients with early myelofibrosis, less contraindicated with interferon, and are very enthusiastic if we see a new patient with early fibrosis in PV to begin interferon treatment. So I want to mention ruxolitinib because this is a subject that bothers both Dr. Hasselbach and myself. The criteria for entering this study, and you saw some of the myelofibrosis trials, was the requirement of having 2 phlebotomies a year. This was the trial using ruxolitinib in polycythemia vera, 222 patients. And the randomization was between Rux and no therapy, or best available therapy, I should say. And you'll notice that 2 phlebotomies per 48 weeks, that's about 4 per year. That's a very low phlebotomy requirement, right? Because I showed you that earlier. Now, if you look at what the patients got in the best available therapy, 58%, nearly 60% of the patients continued on hydroxyurea even though they were resistant or refractory to it. They were resistant or refractory to it and were continued on it instead of being changed to interferon. And another 15% didn't get any therapy at all. So 75% of the control arm didn't get any adequate therapy compared to a new drug therapy. So you have to really look at these entry criteria very carefully when you're a physician involved in these drug trials like we did. Hans wrote an independent article to the New England Journal, as I did, and we were told there were too many letters to the editors, so they didn't publish any of it. But I am bringing this up to you guys. So where do we stand in closing? We have a distinguished colleague out west who pointed out that the survival of patients with polycythemia is impaired compared to normal. We know that. But what he discouragingly pointed out in 2019 was that no progress had been made. We didn't agree with that, so we looked at our survival. The top is the normal lifetime survival of patients age-related to those with PV. The red line you see, the third line down, are those patients with polycythemia vera treated in a certain number of states in the United States. These are government statistics. And the middle line with the green hash marks are those treated at Weill Cornell. So you can see already that we are significantly different from the SEER data with a median survival of 20 to 24 months. The SEER data is like that medical center out west. And our data is shown in the middle, significantly better than the SEER data, but not quite as good as the projected normal survival shown on top. But the answer is shown here that if you take out those patients treated with interferon alone, our survival approaches normal. And we think, therefore, that's why interferon should be used for the initial treatment of PV, and why, if you want to get treated with PV, don't follow that famous statement, go west, young man. So lifelong management, should interferon be discontinued? No, we after treatment success, which is measured by lower JAK level, because we showed that the bone marrow remains hypercellular. And so we're afraid to discontinue just based on the numerical change in JAK2. The French are more liberal, and they do discontinue drug therapy, but there's a lot of psychological factors involved, and that's a discussion of and by itself. Do we think that interferon with these results are curable? No, we do not, but neither is the treatment of CML. You give a lifelong treatment with this drug, and people lead a normal life. And the reason for this has already been touched on by Dr. Hoffman. I completely agree that other mutations may precede JAK2. And if you have a lot of these epigenetic mutations, and these are just listed, he already mentioned them, that they are associated with a poor prognosis. We have the exact same data here. So in conclusion, their evidence is accumulating that interferon is the treatment of choice for PV in both low and high risk ELN, NCN patients. Those are classifications that have been used. Interferon has acceptable toxicity when properly used by an experienced clinician. Interferon has disease-modifying effects, activating dormant stem cells leading to their exhaustion and long-term hematologic and molecular remission. And we should definitely revise the ELN and NCCN recommendations for treatment, which we feel is out of date and inconclusive. Thank you for this privilege of speaking to you.
Thank you, Dr. Silver. Your wealth of knowledge cannot be summarized in 30 minutes.